Today we're going to hear Dr. David Tusek. He's board certified in family medicine and a past ER doctor. He's also founder and CEO of Cloud Medical Direct Primary Care. He was on the steering committee of the DPC coalition based in DC and was invited to the White House to discuss the future of American medicine. Please welcome Dr. David Tusek.
Well, good morning, everybody. Thank you so much for being here. I don't think you could have honored me any more than choosing to be here to listen to this talk rather than being out and enjoying this spectacular Rocky Mountain day. So thank you so much. You know, I describe what I do as functionally informed direct primary care, and I tell my patients we have two main goals. One is optimization, which is to find all the knobs and dials to tune to help people optimize their overall health in the here and now. And then number two is early detection and prevention, which is making sure that nothing jumps out of the bushes to hurt us in 3 or 5 years without warning. And this talk is really about the latter. So the talk is on heart attack prevention, cardiovascular disease in general, and I'm really excited about this topic. And you may be wondering, well, why is this guy so excited about talking about the #1 cause of death worldwide? And I'll tell you, for 2 reasons. First, the tools that we've been waiting for most of our careers are finally here. And second, the understanding that we have of the pathophysiology of how cardiovascular disease in general and heart attacks in particular occur has taken a vast paradigm leap. Certainly since when I was in medical school and residency and training, but really even in the last 2 to 3 years, there's been a real leap in the way that we understand the pathophysiology. And so for those 2 reasons, we now have this immense opportunity and possibility to do something that we haven't been able to do for literally 100 years. Since the advent of penicillin, since the advent of antibiotics, cardiovascular disease has been the #1 cause of death. First here in the US, but then eventually it became the #1 cause of mortality globally, which is where it is now. And we now have the opportunity to do something about that. And I think the particular cohort that we can focus on with these new tools and new understandings are the people that I call the ticking time bombs. Ticking time bombs are the 400,000 people per year that die of sudden cardiac death. And most of those people don't have any warning. They don't have any red flags. They don't have any heads up that there's something wrong. And they're just in their 40s, in their 50s, in their 60s, walking their dog, going for a hike, and suddenly they drop over. And many of them are quite young. Usually when I see people for a 45 or a 50-year-old physical exam, I have this conversation with them and I warn them, I tell them, look, if this hasn't happened already, it's going to start happening. You're going to start getting these phone calls for people that you went to high school with. And they're going to say, man, you wouldn't believe it. Do you remember Joe from high school? He's gone. He had a massive heart attack and he's dead. How did this happen? I mean, even among you here in the audience, raise your hand if either professional in your practice or personally you know someone that has had that. Yeah, most hands have gone up. So why is that? Why are these numbers so stark? Because our conventional diagnostic tools cannot detect those people. Those ticking time bombs are completely invisible to our conventional diagnostic tools. It's not that we haven't tried to find them. We just haven't had the right optics to do so until now. And you may be wondering, well, I'm an integrative primary care provider. I may be a chiropractor or an MD or a naturopath. What does this have to do with me? I think our community is precisely the community. We are the right people to be harnessing these new tools. Because as I mentioned, many of these people are young. And by definition, many of them have no symptoms. They have no warnings, they have no red flags. And therefore, they don't have a cardiologist. But they may have a primary care practitioner. They may have an integrative practitioner like us. And I don't think that there's anything we can do that can have greater impact and greater influence on our overall patient population in terms of mortality and even morbidity improvement than employing these novel technologies in a smart way. And I think that, this whole idea of detecting and diffusing these ticking time bombs is an immense priority and privilege and opportunity that we all have. So, the first thing I want to say is I'm not standing before you as any kind of an expert. I'm not a cardiologist. I'm not a lipidologist or a plaqueologist. I'm just a family doc that loves his patients, as I'm sure all of you do as well. And these new tools have really kind of opened my mind to the possibility of making a much, much bigger impact on people's lives. And, I draw on some of the experiences I had throughout my career, and I spent a lot of time in the emergency room. And I would work in these small rural ERs, mainly on the western slope of Colorado. And I want to tell you about a patient that I saw there a while back. This goes back maybe a little bit over a decade, whose name was Danny. And there was a crackle on the microphone of the radio, and the ambulance was calling in. And they said, hey, we're about 7 minutes out with a 40-year-old male who appears to have had sudden cardiac arrest. When we came on the scene, his crew, his coworkers were administering CPR. And by the time they got to the ER and we received him, he was in PEA, pulseless electrical activity. So those of you that spent time in the ER know that this is probably the most ominous and dire rhythm that you can have, and the prognosis is horrible. The survival rate of PEA, pulseless electrical activity, is somewhere around 2 to 5%. But when they rolled him in, we were like, oh my God, this guy is so young. And the whole team was galvanized, and we were like, we are going to move mountains. We're going to do everything under the sun to bring this guy back, to put him in that 2% category. And so we ran the code. Everybody was bustling and hustling around, and we pushed the first line drugs and the second and the third and the fourth line drugs. Then we went back to CPR. Then we did the whole thing again. Then we tried to defibrillate him, even though PEA is not a shockable rhythm. We thought that might help. Didn't help. So we ran the code again. We pushed the drugs again. And we couldn't let this guy go. But finally, I took off my gloves and I looked at the team and I hugged everybody. And I said goodbye to Danny. And devastated, I walked out of the room, and what happened next, I will never forget as long as I live. I will never forget the voice, and I will never forget the eyes of the woman that literally crashed into me. She barreled into me as I was walking out of the room, and she looked up at me, and she said, "Where's Danny?" And her eyes had these contrasting emotions. The first one was sheer terror. And the second one was this incredible, devoted intentionality to not let a thought into her mind that didn't comport with a good outcome for Danny, for her husband. And she stared at me as I tried to steer her away so that we could sit down and talk. But she wrestled out of my arms and ran into the room. And all I could do, as she lay there, collapsed on Danny's body, weeping and sobbing with the most excruciating grief that I'd ever witnessed in my life, was just hold her and try to comfort her. Because when Danny's heart stopped, her heart shattered. But what got to me was, it wasn't just her heart that was broken. Her mind had broken. She couldn't reconcile the fact that a few hours before that, she was having breakfast with Danny. And they were planning their day. So I tell you this story because a lot of what we're going to talk about is statistical. And, for me, statistics are generally very abstract. It's hard to kind of bring them into some sort of a personal understanding. But now whenever I see these statistics, I think of Danny and I think of his wife. Statistics like every 33 seconds, somebody in America dies of sudden cardiac death. By the time I'm done talking here, there will be another 100 somewhere around the US that have died from this. And this is the real kicker. Of all the people that die from the number one cause of death, half of them, their first symptom is death. All of the people that die of the number one killer, half of them have no idea. They have no warning whatsoever. The other statistic is that this sudden cardiac arrest claims about 400,000 lives annually. Most of these occur out of the hospital, and, as in Danny's cases, they don't survive. And so most sudden cardiac arrest ends up being sudden cardiac death. Again, I can't overstate the impact that this has had on the way that I look at this condition. So I would present to you for your consideration, this is the way I've begun to think about this, that from a cardiology perspective, from a heart health perspective, as primary care physicians, our number one goal really is to find the ticking time bombs. Because they're kind of like this guy. This is an X-ray of a Ukrainian soldier that was shot in the chest with an RPG, a rocket-propelled grenade. And it lodged underneath his ribs right by his heart. And it took a very, very courageous and very delicate surgeon to remove that hand grenade. And this guy ended up surviving. But he knew that there was something wrong. The 400,000 people that are ticking time bombs have no idea, right? And so that's why I oftentimes say, angina is a blessing and a gift. Oh my gosh, doctor, I can't explain it, but for the last few months, whenever I go uphill on my hike or wherever I walk upstairs, I get this weird pressure in my chest. It goes down my belly, sometimes down my arm and up my jaw. It's like, great, you have angina. Is that getting worse? Yeah, it's been getting a lot worse lately. Well, that's unstable angina. What we used to do with those folks is we used to admit them to the hospital, put them on a heparin, watch them overnight, run some tests. Now I just pick up the phone and I call the cath lab immediately. I'm like, the last time this happened, my colleague, interventional cardiologist, Brian Reynolds, picked up the phone and I told him what was going on. He said, send them right in. We still send them through the ER. But while they're in the ER, very, very briefly, the cath lab is already being prepped. And they go in and they get a stent. And they do really, really well. They do really, really well. If they've had stable angina, they may or may not get a stent, but they get an expeditious referral to cardiology. And so angina gives you a warning, gives you a heads up. Hey, we got to get this checked out, either right now or sometime really, really soon. But the ticking time bombs don't have that luxury of angina. So how can this be that 50% or more of people that die of heart attacks have no prior warnings? Well, in order to sort of answer that question, we have to explode a big myth that, quite frankly, persists to this day, certainly in the lay population, and quite frankly, in a lot of healthcare practitioners, of, well, how is it that a heart attack actually happens? The conventional understanding to this day is that it's similar to a kitchen sink that stops draining because it gets more and more plugged with corrosion, and the plaque expands and grows and accumulates, eventually to the point where the water can't drain, the sink backs up, and you have a heart attack. And that, my friends, is nothing at all of how it actually happens. The way that it actually happens is there's an acute event called a plaque rupture. So the top, the fibrous cap of the plaque blows open, and some really bad juju spills out, stuff that's extremely coagulable and thrombogenic, and it causes an immediate clot at the site of that plaque rupture. And it stops all flow distal to where that rupture occurred. So here's the kicker. Most of the time, that plaque is non-obstructive. In most cases of MI, the majority of heart attacks, the plaque that ruptures is non-obstructive, it's non-flow limiting, and therefore it's non-ischemic, meaning there's plenty of blood flowing over the top of the plaque. The heart muscle distal to the plaque is getting plenty of blood flow and oxygen. Therefore, there are no symptoms. So the majority of heart attacks happen to people that don't have prior symptoms. This is pretty freaking crazy. So plaque rupture is the precipitating event of the majority of MIs. It's recently become generally accepted that most plaque ruptures resulting in MI occur in plaques that only narrow the lumen by less than 50%. That's about the cutoff. So if you have a plaque volume that obstructs the lumen of the artery by 30 or 40 or 45%, it's probably not going to be symptomatic. If it's much higher than that, it probably will. This is a diagram of how this looks. So you can see in the diagram that the blood is flowing just fine over the top of that plaque. It's less than 50% obstructive, and it's a non-flow limiting lesion. The plaque ruptures and occludes the vessel right on site. And, you know, a lot of times people think that it's an embolic phenomenon. The plaque ruptures, a clot occurs, and it floats downstream. But what we now know is usually it knocks the vessel out at the site of the plaque rupture, just as it's showed in the diagram. So the bottom line is, those with angina, those with chest pain related to cardiovascular disease, have plenty of warning, but the ticking time bombs do not. They die instantly. So to summarize this part, I know I'm hammering this into you guys, but honestly, for me, studying this stuff, it's been quite an eye-opening revelation. For 50% or more of those who die of the number one cause of death, the first symptom that something wrong is death. Most MIs are caused by plaque rupture, and most plaque ruptures occur in non-obstructing lesions. That's a lot of ticking time bombs. So you may be asking, why are we not detecting these 400,000 ticking time bombs? Because we don't have the right tools. Because all of our tools are designed to pick up ischemic, flow-limiting, obstructive lesions. As an example, some of you older folks may recognize this guy. This is Tim Russert. He was the moderator of Meet the Press. And at age 58, in 2008, he was rushed to Sibley Memorial Hospital, where resuscitation efforts were unsuccessful, and his physician deemed that cholesterol plaque had ruptured in an artery, causing sudden coronary thrombosis, exactly as we've been talking about. But read the fine print at the bottom of the page. He had just performed well on a stress test in late April, and if you look at the top of the page, he died June 18th or 13th. So less than 6 weeks after he sailed through his nuclear perfusion scan, he died of a sudden MI. Why? How can that be? Because nuclear perfusion scans, just like the rest of our conventional cardiology tools, are only looking for areas of the coronary circulation that are obstructed. It's not looking for this mild plaque. I just put this in here to point out that, I Googled the distance from NBC Studios to Sibley Hospital. It's a 7-minute ambulance ride. And it just speaks to how fast these people go, just like Danny. I mean, there's just, not only is there no warning, there's no time to intervene. So this is our diagnostic toolbox that we've all been trained on. We have regular treadmill stress tests, we have nuclear perfusion scans, we have conventional CTA and coronary angiograms, and you may say, well, wait a minute now, even conventional CT angiograms will visualize plaque, even that is non-obstructing. And that's true, and that's certainly beneficial. But the thing that they're missing, which we're going to get into here next, is conventional CT angiograms do not visualize plaque density. And that's probably the most important thing that we want to know. Typically what happens if you have a conventional CT angiogram, if the lesion that's obstructing the artery is in the 20 or 30 or 40% range, it's barely commented on by the radiologist. And if they're not sure, they order something called an FFR, which is fractional flow reserve, to see if there is ischemia that's being caused by that lesion. My point is, that's not enough. That's not going to catch all of these ticking time bombs. EKGs, I mean, they're notoriously unreliable. We still use them. I think they have value, but certainly I wouldn't lean on them as a key diagnostic tool for the detection of these ticking time bombs. And coronary calcium scans, CAC scores, EBCTs, these types of tests, I used to do a lot of. I still use them, but I'll explain to you here in a second why I think these are inadequate for most people. So as a summary, conventional diagnostic cardiology tools only look for flow-limiting, ischemia-causing stenotic plaque, which are amenable to stenting, and that helps. If you have ischemia, if you have angina, getting a stent generally is very, very successful, but it's going to completely miss the non-flow limiting lesions. And as we've been talking about, those are the most common ones that lead to MI. So let's spend a second here on the types of plaque. I call it the good, the bad, and the ugly. So what it really comes down to, and again, this is a very, very complicated process. There's been a lot of science from the perspective of pathology, studying plaque composition, plaque morphology, plaque architecture. what we call plaque phenotype. But the bottom line is this: the more dense the plaque, the more stable the plaque. We said earlier that most heart attacks, in the vast majority of cases, happen when a plaque ruptures. So we want to know the type of plaque that's in there and how likely it is to rupture, how likely it is to do the thing that causes the heart attack. And different types of plaque have different likelihoods of rupture, different rupture-prone qualities. And the higher the density in general, the more stable it is, the less likely it is to rupture. What does higher density mean? Generally, it means it's either scarred down with scar tissue and fibrosis, or it's calcified. So the harder the calcification, the more that calcium penetrates. You know, if you've ever, when I was in residency, I spent some time in the OR with cardiothoracic surgeons, and they let me feel a coronary artery that was full of plaque. And it had the density of coral. Like if you touch coral in a coral reef, it's that hard. So the calcium deposits stabilize that plaque to a very, very profound degree. Whereas lower density plaque, soft plaque, and something that we actually call low density soft plaque is much, much less stable, much more vulnerable, much more likely to rupture. Low density soft plaque is actually composed to a good degree by things that we call foam cells and macrophages that literally cause a frothiness and a fizzing. Think of low density water. If you go out here and look at Lake Estes, that's pretty high density water. It's just sitting there flat. And then you walk up to Calypso Cascades and you see the white water crashing down the cliff. That's very, very low density water. It's full of air. It's full of air bubbles. That's why it's white. Low density soft plaque is very, very similar. It's frothy, it's foamy, it's almost fermenting in there. And that's why it's so likely to do the volcanic eruption thing that we call the plaque rupture. So if only we had a tool that told us not just where the plaque is and how much plaque there is, but what type of plaque we have. That would be a true game changer. So in summary, what's a high-risk plaque? It's low density, it's got a very thin fibrous cap, it's got microcalcification rather than macro calcification. Macro is like a lot of calcium deposit, and it's made of foam cells and macrophages. So back to the CAC score, the coronary calcium score. These are sobering statistics to me, guys, in terms of the sensitivity and specificity of this tool for catching the people that we're talking about, the ticking time bombs. So this was a study from JAMA in 2021 where they found that 58% of people under the age of 40, granted this is a young, very young population, but still 58% of them who had, with subsequent testing, a plaque volume greater than 50%. That's quite a bit of plaque, right? 58% of them still had a 0.0 CAC score. When they got up to their 70s, it was much lower, it was 14%, but that's still a pretty significant number. So again, the precision of using a CAC score, I think, leaves a lot to be desired. A quick slide on, so going through this, like, what do we really want to know? We want to know how much plaque somebody has. We want to know what kind of plaque. Is it the rupture-prone stuff, or is it the really, really stable Mabel plaque? And the third thing we want to know is, where is the plaque? The coronary artery system is not dissimilar from this oak tree. Imagine if we climbed to the top of this tree and we trimmed off one of the branches at the top. What would happen to the tree? Nothing much. The tree would be fine. Now imagine, alternatively, if we took a chainsaw to the trunk of the tree and chopped it down right at the base. The tree would not be very happy. And so the coronary arteries are very similar, right? If we have a heart attack in one of the distal branches in the right coronary artery, those are generally survivable. But if we have a heart attack in what's called the widowmaker, where's the widowmaker? The very, very trunk, right? Here's a diagram. So you can see off of that aorta, the left coronary artery comes off with the main stem called the left main, and then it splits into the circumflex and the LAD, the left anterior descending. If you're very high up in that LAD, or worse, if you're in the left main, you knock out the entire left ventricle. These are not survivable. So the ticking time bombs have multiple misfortunes. They have plaque of the wrong kind in the wrong place. So as we're trying to detect these people, those are really the three things we want to know. How much plaque, where, and what kind. I'm going to shift gears a little bit. I'm going to give you the second case of this talk, and it's going to start with just about a 1-minute video. This is a true American hero. This is the Ironman World Championships in 2019. And a Boulder hero named Tim O'Donnell is in this race. He's at the lead of the pack. Here they're doing the bike ride, so they had just swam 2.4 miles. Now they're biking 112, all before 26.2 mile marathon. So this is T.O. I'll let you enjoy these pictures as he crosses the finish line. This is wife Rinny, also a 3-time world champion.
I'm so humbled and honored. Thank you.
He is a humble man, he's a gentleman, and Tim O'Donnell, second place. What a tremendous day. Did you dream it?
You know what? A couple weeks ago, I didn't think I was going to be doing this race, and it really just filled me with gratitude that I was able to get to the start line. And a good friend of mine, Lawrence, just said, "Open your heart and run." So I did.
Well, you opened it up. We open up our hearts to you, Tim O'Donnell. Second place, Tim O'Donnell, USA.
So this amazing athlete, who was, I think, the second in the history to break 8 hours in Kona, called me about 14 months after this race. And he said, "Dr. T, I'm not feeling so good." I'm like, "Oh, what's going on, Tim?" By the way, he was 39 when he crossed that finish line. So he calls me, he's 40 years old. I was like, "What's going on?" He's like, "Well, I just got done doing another triathlon. I'm in Miami, and I don't feel great. I need to talk through this with you." I'm like, what are the symptoms? And as he went through his symptoms, I cut him off after about 60 seconds, and I said, "Okay, here's the deal, my friend. You need to find 2 aspirin, you need to call 911, and I'm calling the cath lab, you're having a heart attack." And he's like, "What are you talking about? I'm one of the fittest people on the planet. I'm not having a heart attack." I'm like, "Tim, you gotta trust me on this one." So this is about an hour later. He's in the hospital, and he had one of those widowmaker lesions. I believe the only reason he's alive today is that he was so freaking fit. He's such a beast. His heart has so much reserve that it was able to continue pumping just enough to get him to the hospital in time, but most people would not have made it. And thank God for it. Thank God for Tim. Thank God for his beautiful family. He's got 3 gorgeous kids. And few of us would be so lucky. I share this with you because we have this general idea in our mind of like what these ticking time bombs look like. They're probably older, they're probably smokers, probably overweight, don't take care of themselves, pre-diabetic, hypertensive, all the things, right? No. They can happen in the Tim O'Donnells of the world. And this guy's literally on a speaking tour right now, trying to inform people that heart attacks happen to people of all shapes and sizes. So these are sort of 5 paradoxical propositions that were not intuitively obvious to me that I propose to you, present to you. That angina is often a gift and a blessing. It gives us a heads up. It gives us a warning. Not all plaque is the same. Some plaque is very, very benign. It's very, very stable. It's not going to do the heart attack thing. It's not going to rupture. But some of it's bad, and some of it's really ugly, especially the low-density soft plaque. Non-obstructing lesions are the most deadly because they're the main ones that cause the heart attacks. And the location of where we have a heart attack matters. Some heart attacks are a bad day. What happened, man? Oh yeah, I got the ambulance ride, and I had to go to the ER, and then they put a stent in. But then I went home, had dinner with my family, and the next day I was fine. Maybe I was on some new drugs, but my quality of life and my well-being wasn't really dented. Compare that to instant cold death, right? And so our diagnostics, risk calculators, the tools that we've been using have not been successful. So an ideal diagnostic tool would tell us these 4 things. It would tell us where the non-obstructed, non-ischemic, non-flow limiting lesions are, what type of plaque phenotype they were composed of, where they were in the coronary circulation, and obviously we would want to apply these tools to not just older people that kind of fit the profile. So here's that tool. The tool is called the Cleerly Scan. It's an AI-enhanced CT coronary angiogram. The AI technology takes the vessel. You guys saw the squiggly artery, right? It's very tortuous as it goes over the surface of the heart. The AI system pulls it out like a spaghetti noodle so you can really see exactly where the plaque is. And most important of all, it tells you the plaque composition. So in this case, this individual has a risky lesion. He's got a pretty decent amount of plaque, 143 cubic millimeters. Most of it's pretty high up in the LAD. The left side of the screen, that's the left main. It's coming right off of that aortic root. The further down we go to the right, the more distal we are. So he's pretty proximal. And none of it is calcified. So none of it has begun to remodel, to fortify it and stabilize it. So this is a fairly volatile lesion. Most of the plaque is just generic soft plaque, but 23 cubic millimeters of it are the low density ticking time bomb plaque. So this guy went straight to cardiology. He had no symptoms, as you would expect, right? After we've been talking. He went straight to cardiology. We're treating him very, very aggressively. This is a similar lesion, but the composition is different. Same, more or less, amount of plaque, more or less the same part of the vessel, but here, a good amount of it, 52 cubic millimeters, are calcified, and he has none of the low-density, frothy, fulminant, rupture-prone, unstable plaque. this is the kind of detail that we can offer our patients now. And I really want to emphasize all of these points by reading a quick summary from two eminent cardiologists, Peter Stone and Peter Libby, both from Harvard Medical School. And they published this in JAMA Cardiology, December 14th, 2022, so like barely 2.5 years ago. For decades, the medical community focused on plaques that cause severe obstruction of coronary arteries as being responsible for major cardiac events. This approach, called the ischemia hypothesis, has been the accepted strategy for many years. However, while severe obstructive stenoses cause angina, they do not seem to cause the hard events of MI, acute coronary syndromes, and cardiac death. Recent studies like the COURAGE trial, Berry 2D trial, the ischemia trial, have all failed to show a reduction in these hard endpoints by intervening on these severe obstructive lesions. We present new evidence for a new approach, and that is, it's the composition of the atherosclerotic plaques that cause these fatal events, not whether they are obstructive. It's insufficient to just look for obstructive plaques on the coronary angiogram. We are, quote, barking up the wrong tree. We need to look for inflamed plaque at high risk of destabilization, a large area of vulnerable plaque with a thin capped atheroma and a severely inflamed core with microcalcifications, etc. Once plaque is old and not inflamed, it does not cause much of a problem. We can probably just leave it alone. Some of these obstructive plaques may cause some angina, but many do not cause major cardiac events unless they have other high-risk features. Cardiac events are indeed caused by obstruction of blood flow, but that can be a sudden, abrupt process in areas of plaque that were not necessarily obstructed to begin with. Plaque rupture. We believe that this is the explanation behind the observation that 50% of all people who have MI do not have symptoms beforehand. At the moment, we wait for people to experience chest pain or to have an MI. This is far too little, too late. So the plaque hypothesis, which focuses on non-obstructing but unstable plaque, must replace the ischemia hypothesis for how MIs occur. Plaques that are identified as likely to destabilize can be treated with systemic therapies like statins and PCSK9 inhibitors, and these therapies are beneficial, but they are not enough on their own. So these areas of unstable plaque will need to be treated with stenting or something similar. So this is an evolving condition. Our approach to this is evolving, but it's evolving very rapidly. The whole paradigm is changing, and the tools that we can bring to bear can have massive, massive impact. And I believe we're literally at the forefront of being able, again, for the first time since the advent of penicillin, of bending down the mortality curve, mainly by identifying early those 400,000 people per year that are ticking time bombs. And I'm truly grateful to Dr. James Min and his whole team that developed this Cleerly Scan platform. We use it a lot at my practice. I just want to make sure that all of you know that this is available for your patients as well. Thank you so much.